Nursing care of clients with burns. This is part 2, concept of tissue integrity. Major burns cause serious injury to underlying layers of skin and cover large body surface areas. The pathophysiology of major burns involves all body systems, and we will go step by step through each of the body systems to see just how major burns can impact them. So the criteria for a major burn includes a burn that covers over 25% of the total body surface area if the adult is less than 40 years of age, and covers more than 20% of total body surface area if the adult is greater than 40 years in age. Another criteria that classifies a burn as a major burn is if it covers 10% of the total body surface area and it's a full thickness burn or third-degree burn on more than 10% of the body. All injuries involving the face, eyes, ears, feet, hands, and perineum are considered major burns. All burns resulting from high voltage electricity are considered major burns. And all burns involving inhalation injury or major trauma are considered major burns. Jackson's model describes the distinct areas within every burn wound. Centrally lies the zone of coagulation, which represents the zone of severe damage caused by primary injury. These tissues will not recover and will slough off in due course of time. Surrounding this lies the zone of stasis, which is comprised of the less damaged tissue in which inflammation occurs and vascularity is impaired. Tissue in this zone has the potential to recover under the correct conditions. The outer layer, or zone of hyperemia, is tissue with intense vasodilation and increased blood flow. The margins between the zones are not static. They are influenced by local and systemic factors. Reduced blood flow, excessive edema, tend to extend the zone of coagulation and hence the area of tissue necrosis. In favorable conditions, the margin of the central zone remains static and the zone of stasis shrinks as it is replaced by the zone of hyperemia. Finally, we have eschar, which is hard crust that forms over necrotic skin and tissue. This is a duplicate of a repeat question. We had this question earlier, but we'll go ahead and repeat it here. Is it possible to determine the actual extent and depth of burn injury during the emergent phase of the burn? And as we said before, no, it is not. We are not able to determine the actual extent or depth of burn injury because of the swelling and inflammation that can obscure the demarcation of zones of injury. Okay, next let's talk about the pathophysiology of major burns as it relates to the cardiovascular system. The greatest initial threat to a patient with a major burn is hypovolemic shock. It's caused by a massive shift of fluids out of the blood vessels because of increased capillary permeability. And it can begin as early as 20 minutes after the burn. As the capillary walls become more permeable, water, sodium, and plasma proteins, especially albumin, move into the interstitial spaces and other surrounding tissue. The colloidal osmotic pressure decreases with progressive loss of protein from the vascular space. This results in more fluid shifting out of the vascular space and into the interstitial spaces. The net result of the fluid shifts and losses is termed intravascular volume depletion. Signs of hypovolemic shock include decreased blood pressure and increased heart rate. If hypovolemic shock is not corrected, refractory shock and death may result. Also, the CBC results reflect a vasoconcentration, so that the hemoglobin and hematocrit are elevated, which reflects the fact that the fluid has left the intravascular space. In other words, a high hematocrit and hemoglobin is often caused by hemoconcentration due to fluid loss. Of course, after fluid balance is restored, the hematocrit levels and return to normal. Another term for hypovolemic shock related to major burns is burn shock. Major electrolyte shifts of sodium and potassium occur during this phase. A potassium shift develops first because injured cells and hemolyzed red blood cells release potassium into the circulation. Sodium rapidly moves to the interstitial spaces and stays there until edema formation ends. So again, toward the end of that emergent phase, capillary membrane permeability is restored if fluid replacement is adequate. Interstitial fluid gradually returns to the vascular space. Diuresis occurs and the urine has a low specific gravity. At the time of major burn injury, there is increased capillary permeability. All fluid components of the blood begin to leak into the interstitium, causing edema and a decreased blood volume. Hematocrit increases and the blood becomes more viscous. The combination of decreased blood volume and increased viscosity produces increased peripheral resistance. Burn shock, a type of hypovolemic shock, rapidly ensues, and if not corrected, can result in death. Cardiovascular complications can also include dysrhythmias. Burns greater than 40% of the total body surface area cause cardiac dysrhythmias and perhaps myocardial dysfunction. Peripheral vascular compromise is another complication in which blood vessel damage occurs and compartment syndrome follows. Circulation to the extremities can be severely impaired by deep circumferential burns and subsequent edema formation, which acts like a tourniquet. If untreated, ischemia, paresthesia, and necrosis can occur. Compartment syndrome is when it is unrecognized or poorly managed, can increase those pressures, resulting in decreased tissue perfusion. And this is indicated by a darkening and volume loss of the musculature. Blood vessels collapse as interstitial pressure overcomes intravascular pressure, and hypoxic injury ensues, with local tissue ischemia, intracellular edema, anaerobic respiration, and irreversible cellular damage. An escharterotomy, which is an incision through the full thickness eschar, is often done to restore circulation to compromised extremities or improve chest expansion. Once the swelling resolves, then the surgical incision can be closed up again. Let's try another NCLEX style test question. A patient has 20% total body surface area of deep partial thickness and full thickness burn to the right anterior chest and entire right arm. What is most important for a nurse to assess in this patient? Presence of pain, swelling of the arm, formation of eschar, or presence of pulses in the arms. Hopefully, you've decided to choose answer D, presence of pulses in the arms. In circumferential burns, circulation to the extremities can be severely impaired, and pulses should be monitored closely for signs of obstruction by edema. Swelling of the arms would be expected, but it becomes dangerous when it occludes blood vessels. Pain and eschar are also expected. Let's try another NCLEX style question. During the early emergent phase of burn injury, the patient's laboratory results would most likely include and if you're leaning toward A, you would be correct. Increased hematocrit, decreased serum albumin, decreased serum sodium, and increased serum potassium. With increased capillary permeability, water, sodium, and plasma proteins like albumin leave the plasma and move into the interstitial spaces, decreasing serum sodium and albumin. Serum potassium is elevated because injured cells are hemolyzed and release potassium from the cells. An elevated hematocrit is caused by water loss into the interstitium, creating a hemoconcentration. What is the initial cause of hypovolemia during the emergent phase of burn injury? A, increased capillary permeability. B, loss of sodium to the interstitium. C, decreased vascular oncotic pressure. And D, fluid loss from denuded skin. The answer is A. Although all of the selections add to the hypovolemia that occurs in the emergent burn phase, the initial and most pronounced effect is caused by fluid shifts out of the blood vessels as a result of increased capillary permeability. Clients who are critically burned are at high risk for which complication during the resuscitative phase? And hopefully you selected burn shock, C, burn shock. Now the emergent phase is also called the resuscitative phase, and it's the time needed to resolve the immediate life-threatening problems resulting from the burn injury. This phase usually lasts up to 72 hours from the time the burn occurred. The main concerns are the onset of hypovolemic shock or burn shock and edema formation. The emergent phase ends when fluid mobilization and diuresis begin. Smoke and inhalation injuries from breathing noxious chemicals or hot air can damage the respiratory tract. 3 types of smoke and inhalation injuries can occur: upper airway injury, lower airway injury, and metabolic asphyxiation. Smoke inhalation injuries are a major predictor of mortality in burn patients. Rapid initial and ongoing assessment is critical. Airway compromise and pulmonary edema can quickly develop within hours of injury. In fact, most deaths at a fire scene are the result of inhaling certain smoke elements, primarily carbon monoxide or hydrogen cyanide. Oxygen delivery to or consumption by tissues is impaired, resulting in hypoxia. Upper airway injury results from an inhalation injury to the mouth, oropharynx, and/or larynx. The injury may be caused by thermal burns or the inhalation of hot air, steam, or smoke. The swelling can be massive and the onset rapid. Burns to the neck and chest may make breathing more difficult because of the burn eschar, which becomes tight and constricting. Edema from facial and neck burns can be lethal, as can internal pressure from edema narrowing the airway. Obstruction can occur quickly, presenting a true airway emergency. An inhalation injury to the trachea, bronchioles, and alveoli is usually caused by breathing in toxic chemicals or smoke. Tissue damage is related to the duration of exposure to toxic fumes or smoke. So carefully assess the patient for facial burns. Any singed nasal hair, hoarseness, painful swallowing, darkened oral and nasal membranes, carbonaceous sputum, and clothing burns around the neck and chest. Pulmonary edema may not appear until 12 to 48 hours after the burn. Then it may manifest as an acute respiratory distress syndrome. Once again, remember, burns of the head, neck, and chest and back mean that we need to monitor the respiratory system of this client. And if we assess wheezes, then it would be very important to tell the physician, because this patient may need to be mechanically intubated before the swelling completely occludes the airway. Okay, moving right along to the gastrointestinal system in our major burn patients. The dysfunction of the GI tract is going to be related to the size of the burn wound. A paralytic ileus may result from a major burn. Stress ulcer is common in patients with burns to more than 35% of their body surface area. Another name for this stress ulcer in burn patients is Curling's ulcer. And finally, we can have an ischemic bowel that leads to bacterial translocation and sepsis and multiple organ dysfunction. Now let's look at the pathophysiology of major burns as it relates to the urinary system. Early on, there's decreased renal blood flow and glomerular filtration rate. The red-brown discoloration of the urine, seen on the left side of the picture, suggests hemoglobinuria, hematuria, or myoglobinuria. The red discoloration of the serum or plasma to the right indicates that hemoglobinemia is present, and this probably produced the hemoglobinuria. Okay, so And that can certainly result in renal failure, as we've discussed that pathophysiology before. When you have hemoglobin or myoglobin, these very large molecules going through the kidneys can actually occlude or obstruct the little renal tubules, and this can lead to renal failure. The immune system is impaired with major burns. Both the cell-mediated and the humoral immune system are impaired, putting the patient at high risk for infection. A burn injury challenges the body's immune system. The skin barrier to invading organisms is destroyed. Bone marrow depression occurs and circulating levels of immunoglobulins decrease. Defects occur in the function of white blood cells. Thus, the patient is at a greater risk for infection. Metabolism is also impaired with major burns. There are 2 stages. The first 3 days describe the ebb stage with a decreased oxygen consumption, and then that is followed by the flow stage where the basal metabolic rate is increased. This occurs after burn resuscitation is accomplished. During the flow stage, the patient will require lots of calories and lots of protein. And so for that reason, oftentimes these patients will be given a burn shake, because a burn shake is going to have lots of calories and protein so that these patients can heal during this increased metabolic rate period. There are 3 stages of care for our burn patient. The first stage is the emergent or resuscitative stage. The phase usually lasts up to 72 hours from the time the burn occurred. During this phase, fluid resuscitation needs to occur. The fluid of choice is a warmed lactated Ringer's, and also you will follow a formula so that we can administer the correct volume of fluids to these patients for an adequate resuscitation. And these patients will need 2 large bore IVs for venous access. Okay, by large bore we mean 14 to 16 gauge needles. The emergent phase is followed by the acute stage, and this stage may last anywhere from weeks to months. The acute stage begins when extracellular fluid is mobilized and diuresis occurs. Finally, there is the rehabilitative phase, and this begins when wounds have healed and the patient is participating in self-care. Okay, do spend a little time with knowing what each of these 3 phases of care entail. Okay, the patient was admitted to the burn center with a full thickness burn 42 hours after the thermal burn occurred. The nurse will apply actions related to which phase of burn management for this patient's care. If you thought the answer was B, emergent, then you are correct. Because remember, this phase usually lasts up to 72 hours, and so 42 hours certainly falls within that time frame. Let's discuss the aim of fluid resuscitation with our major burn patients. The aim is to prevent burn shock by giving adequate fluid without overloading the vascular system or causing excessive edema. An aim of fluid resuscitation is to maintain circulatory volume in the face of losses due to the burn. This is essential for cardiac output, renal perfusion, and tissue perfusion. Another aim of fluid resuscitation is to maintain tissue perfusion to the zone of stasis and prevent the burn from deepening. Fluid moves to areas that normally have minimal to no fluid, a phenomenon termed third spacing. Examples of third spacing in burn injury are exudate and blister formation, as well as edema in unburned areas. Other sources of fluid loss are insensible losses by evaporation from large denuded body surfaces and the lungs. The net result of the fluid shifts and losses is termed intravascular volume depletion. Burns of more than 15% of the surface body area in adults and of over 10% in children warrant formal fluid resuscitation. We will use a standardized formula to estimate the patient's fluid resuscitation needs. Fluid replacement is achieved with crystalloid solutions, usually lactated ringers, also with colloids like albumin, or a combination of both. IV saline is usually started during the pre-hospital phase. The Parkland formula for fluid replacement is the most common formula used. Remember that all formulas are simply estimates. Fluids must be titrated based on the patient's response, such as their hourly urine output and their vital signs. The replacement volume is calculated based on the patient's body weight and the total body surface area burned. Okay, so I want you to memorize this formula. It's not very difficult, but the volume that you're going to calculate to resuscitate a patient in the first 24 hours is going to be 4. That's a factor. We're just going to choose 4 for our purposes, times the total body surface area as a percentage, times the body weight in kilograms. Now, half of that volume is going to be given over the first 8 hours after injury, and the other half of the volume is going to be given over the remaining 16 hours of that 24-hour period. So let's look at an example. We have a 70-kilogram patient with approximately 50% of the body surface area burned. So we take the factor of 4, multiply it by 50%, and multiply that by the patient's weight in kilograms, which is 70. And that comes out to a grand total of 14,000 milliliters over 24 hours. Therefore, 7 liters, which is half of the 14,000, should be given in the first 8 hours after the burn injury, and the remaining half, or 7 liters, should be given over the following 16 hours. Again, regular assessment of the adequacy of the resuscitation efforts should be done. Blood products and colloids may also be given in addition to these fluid requirements. Let's answer an NCLEX-style test question. A nurse is providing care for a severely burned client during the shock phase of the burn injury. Which assessment findings would indicate that the client is receiving adequate fluid volume replacement? Hopefully, you're thinking that B is the correct answer. Indeed it is, because a urine output of 50 mL per hour is adequate. The blood pressure is stable, and they have a clear sensorium, and the fact that they are oriented to person and place. And those are all positive signs that adequate fluid volume replacement is occurring. Again, we would want to see that the pulses are easily palpable as well. Here's another question. An adult was burned in a house fire 16 hours ago. She suffered second and third degree burns, over 65% of her body. She is receiving lactated ringers at 200 milliliters per hour. Which intervention is a priority at this time? Monitoring hourly urine output, assessing for signs and symptoms of infection, performing range of motion every 1 to 2 hours, meeting the high caloric needs of the client. Given these choices, I hope you selected A. Urine output is the most readily available and reliable indicator for determining the adequacy of fluid resuscitation. Urine output should be monitored every hour and maintained between 30 and 50 milliliters per hour. Once a patent airway, effective circulation, and adequate fluid replacement have been achieved, priority is given to care of the burn wound. Promote the use of analgesics for the patient's comfort. Early in the post-burn period, intravenous pain medication should be given because the onset of action is fastest with this route. Oral drugs have a slower onset of action and are not as effective when GI function is slowed or impaired because of a paralytic ileus or shock. Opioids are the drug of choice for severe pain in the early stages of care. When given appropriately, these drugs should provide adequate pain relief. After the wound is cleansed, topical antimicrobial agents may be applied and covered with light dressing. Systemic antibiotics are not routinely used to control burn wound flora because the burn eschar has little or no blood supply, so little antibiotic is delivered to the wound. Some topical burn agents penetrate the eschar and inhibit bacterial invasion of the wound. Silver impregnated dressings can be left in place from 3 to 14 days, depending on the patient's clinical situation. Silver, in the form of Silvadene, these creams are used and applied topically. All burn patients routinely receive a tetanus toxoid because of the risk for anaerobic burn wound contamination. If the patient has not received an active immunization within 10 years before the burn injury, tetanus immunoglobulin should be considered. Aim to prevent Curling's ulcer by feeding the patient as soon as possible after the burn injury. Antacids, H2 histamine blockers and proton pump inhibitors are used prophylactically to neutralize stomach acids and inhibit histamine and the secretion of hydrochloric acid. Bronchodilators may be given to treat severe bronchospasm in airway management, especially if their severe respiratory distress begins, then they would certainly begin bronchodilator use. When the patient's open burn wounds are exposed, always wear personal protective equipment, such as disposable masks, gowns, and gloves. When removing contaminated dressings and washing wounds, use non-sterile disposable gloves. Use sterile gloves when applying ointments and sterile dressings. And of course, before leaving one patient, remove your PPE and wash your hands. Don new PPE before you treat another patient. You can perform cleansing and gentle debridement using scissors and forceps on a shower cart, in a regular shower, or on a patient's bed or stretcher. Extensive surgical debridement is done in the operating room. During debridement, necrotic skin is removed. Another type of debridement is enzymatic. With enzymatic debridement, we use a topical enzyme agent to dissolve and remove necrotic tissue. One example of this would be ELASE, E-L-A-S-E. This ends in ASE and reminds us that it is indeed an enzyme. So it breaks down clots and fibrin strands. And there's another one called collagenase, which is Santyl, S-A-N-T-Y-L, and it also ends in ASE, collagenase, ASE, and it helps also to dissolve necrotic tissue. Two approaches to burn wound treatment are the open method and the closed method. In the open method, the patient's burn is covered with a topical antimicrobial and has no dressing over the wound. This approach is usually limited to the care of facial burns. In the multiple dressing change or closed method, sterile gauze dressings are impregnated with or laid over a topical antimicrobial. These dressings are changed from every 12 hours to once every 14 days, depending on the product used. Most burn centers use the closed technique. When wrapping fingers and toes, it should be done in the distal to proximal fashion, and each digit should be wrapped separately. This is to prevent scarring and contractures. Work with physical therapy to perform range of motion exercises during dressing changes and throughout the day. Movement aids the shift of the interstitial fluid back into the vascular bed. Active and passive exercise also maintains function and prevents skin and joint contractures. And it may reassure the patient that movement is still possible. A hypermetabolic state proportional to the size of the wound occurs after a major burn injury. Resting metabolic expenditure may be increased by 50% to 100% above normal in patients with major burns. Core temperature is increased, Catecholamines, which stimulate catabolism and heat production, are increased. Massive catabolism can occur and is characterized by protein breakdown and increased gluconeogenesis. Failure to supply adequate calories and protein leads to malnutrition and delayed healing. Calorie-containing nutritional supplements, such as burn shakes, are often given to meet the caloric needs. Okay, let's go through a step-by-step of how we might dress a burn wound. And this would be the closed method. And first we might apply the Silvadene cream to the wound very gently so as not to cause any further tissue trauma. And again, you should have sterile gloves on in this method of spreading the cream. And then cover it gently and lightly with 4x4 sterile gauzes. Next, you will begin to wrap it with the roller gauze or Kerlix. And finally, when it's all wrapped up and finished, you don't have to tape it, just leave it as it is. And this is not done in a tight manner, so we do not want to cut off any circulation, but just simply to cover it like this with the Kerlix. Anti-deformity positioning prevents scar contracture across joints by placing them in flexion, extension, hyperextension, or abduction. The correct answer here is A, flexion, but again, it's not a severe flexion. It's more as if the patient had their hand wrapped around a can of Coke. So there is a slight flexion to the positioning that is going to be best for improving function as the scarring occurs. You may also use splints at times to help position hands and feet in a position of function. It would be, if you are using splints, then it would be important to inspect the skin and the bony prominences to avoid areas of pressure from inappropriate or prolonged application. A patient's deep partial thickness facial burns are treated with the open method. What should the nurse do when caring for the patient? The correct answer is B. Wear a cap, mask, gown, and gloves during patient contact. Remember, when the patient's wounds are exposed with the open method, the nursing staff must wear caps, masks, gown, and gloves. A client is admitted with severe flame burns resulting from smoking in bed. The nurse would expect the room environment to include which of the following? The correct answer is strict isolation techniques and policies. Infection can cause further tissue injury and possible sepsis. If sepsis is suspected, obtain cultures, and including of the burn wound itself. You can also get other cultures such as blood, urine, sputum, etc. Nursing diagnoses appropriate for burn patients may include altered skin integrity, altered fluid volume, first deficit, and then excess. Deficit during the first hours when the emergent phase, when they are at risk of going into burn shock. and then excess during the fluid resuscitation stage. Another nursing diagnosis would be the acute pain. It's very painful, no matter what degree of burn they have. Even third-degree burns are extremely painful. And so we have to even remember to medicate these patients prior to doing their range of motion exercises. Okay, so it's very important to do range of motion exercises to prevent contracture formation. However, if it's too painful, then they're not going to want to do it. So make sure you medicate your patients for pain before any physical activity, even if they have third-degree burns. I should probably say especially when they have third-degree burns. Risk for infection is another nursing diagnosis, because infection is really what many of them succumb to. Many of them die as a result of infection in their because of their wounds. Impaired physical mobility, especially related to contractures. A joint contracture is a flexed and fixed abnormal condition of a joint, and it develops because of shortening of the scar tissue in the joint. So it's very important that we prevent contractures from developing. Imbalanced nutrition. We have both, we have less than body requirements, especially during the flow stage, as we mentioned. They need so many calories that we can hardly give them enough. So they are at risk of imbalanced nutrition during this flow stage. And powerlessness. Because of the tremendous psychological impact of a burn injury, we need to be particularly sensitive to the patient's emotions and concerns. The primary goals related to burns is prevention and reduction in the incidence of burns. Burns are commonly received in residential fires, so properly placed and working smoke detectors, in combination with rapid evacuation plans, will minimize a person's exposure to smoke and flames in the event of a fire. And children must be taught never to play with matches, lighters, fireworks, gasoline, and cleaning fluids. And certainly adults need to be reminded, if they are a smoker, not to smoke in bed. Also, we need to take care and be observant when using candles. Also, it's good to promote the teaching of first aid for burns. Inhalation injury is a frequent burn complication resulting in upper airway edema. During which time period? The answer is C, 24 to 48 hours. The resulting edema in the airway peaks within the first 24 to 48 hours of injury. An adult's shirt catches on fire and is now in flames. He panics and runs into his neighbor's yard. Which of the following interventions is appropriate? Select all that apply. Dousing the flames with water? Yes. Removing his jewelry? Yes. Hot metal jewelry could increase burning. and rings should be removed before edema occurs. Rolling him on the ground? Yes. So according to a textbook, the correct answers would be A, C, and D. However, if you want to argue some other answers, I wouldn't be too worried about this because some people really want to remove this person's clothing. And I know that sometimes they do say to do that. But what they want you to get is that dousing the flames is an appropriate way to smother flames with large amounts of water, right? That's good. And remove jewelry because that can end up with compartment syndrome or even further continuation of the burning process. And always rolling on the ground to smother the flames is a good move as well. But do not get too concerned about this. You won't see this question again, but it's just some food for thought here. Okay, the preferred diet for severely burned clients is the correct answer is C. We need a high protein, high calorie diet for these patients. A patient with deep partial thickness burns over 45% of his trunk and legs is going for debridement in the cart shower 48 hours after the burn. What is the drug of choice to control the patient's pain during this activity? And A is the correct answer. The drug of choice is intravenous morphine. Morphine is a drug of choice for pain control, and during the emergent phase, it should be administered intravenously because GI function is impaired and intramuscular injections will not be absorbed adequately. Identify the factors that increase nutritional needs of the patient during the emergent and acute phases of burn injury. Select all that apply. Okay, so hopefully you got B, C, and E. There is a hypermetabolic state proportional to the size of the burn, which increases the core temperature. Massive catabolism can occur and lead to malnutrition and delayed healing without adequate calorie and protein supplementation. The electrolyte imbalance has more effect on the fluid resuscitation than the nutritional needs.